For folks on the phone, we'll be getting started in a minute or two. Or if we stand like this. So we're gonna, yeah, we probably would. Yeah, there you go. Stand from there. Sure. No, it's fine. So we'll be getting started in just a moment. If folks can sort of find their way to some seats. So did you want to start with that? Yeah. Okay.
So welcome everybody. This is day 2 of the 1004 meetings. I want to welcome the Colorado Hospital Association, the consumer advocates, the brokers, both of our shops. Who did I forget? The carriers. Who else? Providers. I said hospital association. Okay. So if I forgot anybody, it's Kim's fault. So get mad at her. But really, we're excited to be here today to have the conversation. So this is going to be a little bit different than the first time around. The first time around, we really presented to you all. We kind of tried to do a base level groundwork presentation of different ideas and different things to think about. Today, we're really going to turn it over to you. We want to hear from you all. Lorez is going to be driving the boat here. But the whole idea for today is for you all to have a conversation amongst yourselves so that Kim and I can get your thoughts and listen in. Obviously, if you have questions that are specific for us, we'll chime in. But the hope today is really that we don't talk, with the exception of one slide towards the end. But like I said, if there's something that we need to weigh in on, we won't be shy. But with that, Lorez, we'll turn it over to you and let you kick off.
Great. And so looking forward to hearing from all of you. And so what that means is if folks can really be concise and to the point, if somebody has said something that you agree with, just say ditto or echo that point. I will call probably on folks we haven't heard from before calling on folks that maybe have already gotten a chance to speak, but I will try to get to everybody. And so hoping that this is going to be a very robust conversation to really help start thinking and the shaping of this. So our agenda today is sort of just did the welcome introductions. We're going to again go the purpose and goals of the process so that for folks that weren't here before can see that again. We're going to first sort of open it up and start that conversation around population eligibility levels for whom we're building this for. So let's talk a little bit about who are we building it for, and then talk about one of the other key components in the legislation was around affordability. And what does that mean? And then there is also a piece that talks about existing state healthcare infrastructure. So what does that mean to you all as well? So really, again, this is going to be an opportunity to hear from you all. And so just to be fair and transparent, when Mike says, if you ask questions, I'm likely to turn that question back to you all and ask you what you all think. So use those questions wisely as they will come back your way. And with that, we are going to jump in. I just want to recognize we do have, this is a webinar, so we have people joining us by phone. So on occasion, I will be calling on Vince to share maybe comments and thoughts from folks that are on the webinar as well. Ian is helping me run around the mic. This is a big room. And so if we don't get the mic quite to you, just give us a second to repeat the question to make sure that everybody can hear it, and we can make sure that folks on the phone are following along as well. So again, quickly, the stakeholders' roles in these recommendations are to provide input to the Division of Insurance, Healthcare Policy and Financing in the development of the recommendations to the legislature. Constraints, as always, the recommendations will also be accompanied or need to be accompanied by any needed legislative change or any fiscal funding requests And so again, that means that there will be other decision makers in this process. Stakeholders' responsibilities is to be thought partners, identify additional needed input. If we're not asking all the right questions, let us know what questions we should be asking. And I'm so glad you all are in the room, but you represent many people as well. So your job is to bring back some of these questions and bring back other thoughts. So knowing that we can't have one broker represent the entire broker community, how do you share with others? Same with hospitals, same with docs, same with advocates. So again, we're trying to get full and robust as we try to cover the state. Timeline, these recommendations are due to the legislature by November 15th. So really, it's an accelerated timeline to have a lot of conversations to inform that, so that we can sort of bring the draft recommendations back to you, likely in September-ish, end of August, beginning of September. Loose deadlines, unless it's printed up there, it's a loose, but just to give you an idea. So with that, we are moving on. So the first question, the first thinking that I would like from all of you is, who should this public option be available to? We've thrown some thoughts up there: uninsured, underinsured, residents. Are there other target communities? Should there be an eligibility cap? Are we talking about the small group market, individual market, and sort of other considerations? Yes, Bob.
Can we ask you a question? I've got a question that doesn't quite that yet, but it's a good umbrella question over the discussion.
Let's take it, Bob, and we'll see if we answer that or if I'm going to turn it right back to you.
Okay, fair enough. Hold on. Anyway, one of the questions, we're representing people on the West Slope in rural areas. And one of the concerns that we have, we've been doing research on charge masters that are now public in all the different hospitals, and we see these massive price variations that happen on the West Slope and in some rural areas. There are outliers in the Front Range, but you tend to see it more when you're talking about rural areas. The concern that I have with the public option over the long term is its sustainability. We don't really know what a lot of these healthcare costs actually are right now. We have no trend line for how they're going up. We don't understand really where the drug pricing goes. My concern is, if we don't do something about the driver of healthcare costs being healthcare costs, we have no control over them. We don't exactly know where they're at. How will the public option maintain its fiscal sustainability over time?
That is a great question, and when we get to affordability, I will flashboard for a second. The underlying costs of care will be included in the definition of affordability, so recognizing cost of care are not separate from what we're talking about, and I think sustainability is forefront of the mind. So yes, and we should continue to bring this up through the process to make sure that we truly are. But again, I think we wanted to start with who are we building this for, and then go into what does affordability look like and those costs of care. Thank you. Yes, please, Allison.
Oh, Bethany, actually.
Bethany, so sorry.
Online policy. We would, partly for the sustainability concern, I think it's worth having an option that addresses the needs of the whole range of population. That would allow potentially an option to remain sustainable should the one insurer counties change, should there be other kinds of shifts in population. If you have a product that's targeted only to a subset, that's not going to be as possible. So we would recommend addressing the full range and not having an eligibility cap.
Okay, great. Thank you, Bethany.
Deb Judy at CCHI. I will ditto that. I think many of the consumer groups that have talked about this so far do feel that this should be an open to all. And I would, I guess, highlight as well thinking about people without proper documentation in this process.
Other thoughts about for whom?
Ditto to Deb Judy. She took the words right out of my mouth. But when I think of public option, I think of being open to everyone, not just those on public assistance or who have Medicaid. And it seems to be the default position that public options are only for those who are receiving some sort of help from the government. So I think it would be better to open it up and allow it to truly be a public option.
That sounds great. Thank you, Jean. And a reminder, just introduce yourself too. I think everybody's been pretty good about that so far.
I'm Paula Stepp. I'm with Western and Rural Colorado Healthcare. What I'd also like to see in incorporating that in the small group markets is, I know so many people who are in a gap of, I want to start a small business, I want to do this, I want to provide for my 1 or 2 employees, and to have that incorporated in that somehow, I think would be helpful.
I just wanted to add one thing. First of all, I want to thank CCHI for having a wonderful phone call with New Mexico and Connecticut in the last few days, where we heard from some best practices or worst experiences, whatever you want to call it. Anyway, they, in their #1 plan for eligibility, I'm sorry?
Introduce yourself.
Oh, Carol Pace. I'm a consumer, but
Perfect, Carol.
I'm an AARP member as well. And other groups. And the one interesting group that they identified in their #1 plan, they call the family glitch, where an employer pays well for an insurance plan for the employee, but the spouse, children, and so forth may be on a plan that's quite costly, and so therefore they're in a kind of a gap. It's like COBRA. You're eligible for COBRA, but if it's 4 times what you can afford, it doesn't help. So New Mexico had 4 groups in their plan. I believe it was individual, and it was this family glitch, and there were 2 more. Anybody who was on that phone call remember who New Mexico identified? But they had worked this out. Thank you.
Great. Thank you, Kara. Other thoughts? So while we're walking, I was going to let Vince talk. There's some comments from the phone.
Yeah, just one question so far. Or comment. I think it echoes what some people have said, but it's important to build this for people over 400% of the federal poverty level who are uninsured.
Great, thank you. Yes, sir.
I'm John Levitt. I run a network. I do payer relations and payer contracting for 10 rural hospitals. When I think of underinsured, do we have a definition of underinsured? Because in rural areas, if your attachment points for getting on the exchange are thousands of dollars on the individual market and thousands plus for the family, our experience, it's not just what we consider, but our experience is those are self-pay patients largely. So they never see their deductible. We don't treat the kinds of things usually in rural communities that get charged that much. But in terms of costs, we don't know what costs are either. That takes a fairly sophisticated, expensive system. And 8 out of 10 that I represent are critical access hospitals. Yeah. My intent is to put as much input into the difference between how Medicare pays them, critical access hospitals especially, and how Medicaid started to with the APGs and such, because Medicare realized we can't make that on prospective payment. Most of my hospitals don't have a bottom line, period. So we're real sensitive.
Great, thank you. Other comments or thoughts on, yes, sir.
My name is Steve Reynolds. I'm the Healthcare Committee co-chair for Club 20 from the Western Slope. And I want to reiterate some of what's already been said. And I worked as a broker for a couple of years helping people get on the exchange. And I think that keeping these definitions relatively flexible is important, because we already heard about the family glitch. We've talked about the churn where people change their income levels. There's a lot of people that fall in and out of different categories when we make hard and fast categories. So I think that having the ability and the flexibility for people to get into the system at some level is going to be really important.
Great, thank you. Yes, sir.
Bob Shively, and I'm with the group Western and Rural Colorado Healthcare. I think to me, and I think to our group, overarching all of this is that we figure out how we can truly move to a transparent and some transparency that is better than what we're trying to do now. I think that needs to happen. We need to know what we're paying for. We need to know that this is going to have a long-term effect and not a short-term.
Great, thank you. Anything that has not been said yet? All right. So as we saw, some of the conversation around who is eligible went into the affordability piece. So with the conversations around underinsurance, what does that mean? And so the legislation talks about affordability, but also going to pose some of these questions as well. What are we trying to address? Is it the premium? Is it the out-of-pocket cost sharing? That could be deductibles, co-payments, co-insurance. Is it for those in worse health or with chronic disease? Those foregoing cost care because of the cost, or both? Is there a percentage of income for health insurance coverage to determine affordability? There have been percentages put out of there, and then is this individual or family? Again, we've heard about the family. We know as well in the ACA there is the 9.6% that is for individual that excludes family, and that can make it unaffordable. And I think we raised the issue of those transition points as well so far. But and again, just to echo, the underlying cost of care will be included in the definition of affordability. So cost of care is part of that consideration. But again, really talking about what does affordability mean to you all? And again, you ask me questions, I'm going to turn them back around to you. So let me hear your thoughts. I'm sorry. Bob, did you want to, I know you wanted to follow, was there something else you wanted to address related to cost of care?
To me, the issue is...
One moment, Bob.
Sorry, I didn't want to take anybody's question away.
Hopefully it's not a question, more it's a statement.
Well, more of a statement. I think part of the issue is that in terms of affordability, the more people that we take into this, we should obviously try to help everybody we can, especially those people above 400% of FPL who don't get any kind of assistance when it comes to any kind of health insurance premiums, and we have a huge amount of that in the West Slope. My issue is beyond that. My issue is the sustainability of that. If we can afford this stuff individually, I mean, if we can afford this stuff for a while, if we're talking about increased cost of health care, and I'm not talking about premiums now, I'm talking about the cost of a procedure, a DRG code, a CPT code, whatever it happens to be. What I'm concerned is that we might find ourselves in a position, especially on the West Slope, since we have a disparity in terms of the cost of healthcare out there versus, say, for example, the Front Range. And I'd recommend that if you take a look at charge masters for various hospitals, you'll see a certain amount of what that variation is, and it's massive. We can have situations where the price of one particular MSDRG code is 500% higher in one hospital than another. Now, because we don't have a baseline of what these costs are outside of those charge masters, which are very hard to read, we also don't have a trend line for how costs continue to grow. So my concern is we can add a lot of people to the mix. We can take everybody that was on your first slide. The question is, how sustainable is that over the long term? Are we a guy on foot trying to outrun a train in a tunnel? That those prices will eventually catch up to us, and then we're going to have an issue with trying to make this program sustainable over the long term, especially in a taper state.
Yeah.
So that's kind of where I'm going with.
Okay.
That's what my concern is.
No, and I think it's very important to, I think, everybody sort of that cost of care is a key component of this to make it sustainable. Yes.
This is Kim. I'll add just a couple of things. That first, I really appreciate the question because the importance of understanding the ecosystem of healthcare is really critical. whether the monies are coming from a left pocket or a right pocket, you're paying for the underlying cost of care. And I hope that you've seen in the last year that we're spending a tremendous amount of time on that. So there was a transparency bill on the hospital side passed in two ways. One was the cost, underlying cost, but the second, or the how much money is coming in, where's that money going? And then there was the bill that says, where does that money go relative to community health needs assessment? Thank you for our advocates to running point on that. Expect a lot of pharmacy reports coming out targeting August 31st, which will be a huge 15 drivers of pharma, lots of solutions that can inform what do we do about that. We're having some wonderful dialogue with the Hospital Association through Hospital Transformation Program because they're behaving in the way that we paid them to. And they're competing with each other as best they can. And sometimes those competitive forces actually cause costs to go up. So we're actually in wonderful dialogue with the Attorney General and the Hospital Association. How do we help them collaborate so that the ones that do charge the 500 and 700% of the other, maybe that's not a business that you should be in. And maybe we should pay you to refer. So there are lots of neat things going on. So I want to, one, thank you for your question. Two, know that it's getting a ton of attention right now, including the budget that we gave to Civic in this past budget that starts actually July 1st in a couple of weeks. Retooling Civic so that they can provide a wealth more of information that gets at the root of what's causing the issues so that for everybody, regardless of where the money's coming from, regardless who the payer is, that we've got better insights into what we need to do to make it more sustainable, regardless of who's paying. So thank you for your question, and know that it is absolutely critical in defining affordability as what's the underlying cost of care.
We'll go there, and then Vince. Yes.
Good morning, Josh Ewing with the Colorado Hospital Association. I want to kind of piggyback on that conversation a little bit because we know so much of what drives the costs are inputs and upstream factors. How is a health plan going to impact those upstream factors, and specifically how are in building underlying costs into the definition of affordability? Can you just elaborate a little bit on how that's going to get at those upstream factors?
So how would you think? What are your thoughts?
Very good.
I wonder about the levers available to a public option health plan to do some of that. I think Kim touched on a great project, the Hospital Transformation Project, that's looking upstream. But we also have workforce costs and a variety of factors that lead into that are kind of outside of probably the scope of what a plan can do. And so I want to be cautious that we're not trying to bite off too much, I guess. I have lots of thoughts about how we can dress up those upstream things,
yep.
But I don't know that this is the vehicle for that.
Okay. Great, thank you. Vince, comments from?
Yeah, 4 questions and comments. Can I go through them all?
Yep.
Great. All right. One, this question I think harkens back a little bit to the eligibility. It came in just after we wrapped that up. But I think it also touches a bit on affordability. How much do we need to consider the viability of the waiver/option program when we create the eligibility list? I'd hate to see us aim for the highest heights and get nothing, but I'd also hate to see us aim too low. Sure.
If we know, we can say. I think sometimes on webinars people don't always have a name, but
that was from Dana Bacon. All right. Chantrell Ormsbury asks or comments, affordability is health insurance premiums. The deductible and out-of-pocket people can get help through the hospitals with the CICP or indigent programs, so really not an issue on the Western Slope. David Galenda says, affordability varies based on total cost. The question needs to address both monthly insurance costs plus what we pay when we use healthcare. There is no transparency in either premiums for insurance or healthcare delivery systems. And I've got a couple more. Andrew Rose, Director of Boulder Educational Wellness. Deductibles exceed 10% of annual income. Deductibles exceeding 10% of annual income are difficult. Limiting deductible size and tying to income could make sense.
Great. Why don't we pause it?
Yeah, sure.
Okay, thanks. Yes.
John Levitt, work in rural care. I applaud anybody that's actually taken the efforts to look at the charge master issue. For those of you who don't know, it'll cross your eyes in about 5 minutes. But my hospitals are largely public. They're districts or they're county hospitals. They're taxing entities. And I can tell you for the last 10 years what all 10 of them have done in their trends in terms of price increases. I'm real concerned because I've worked in rural care in Colorado for 30 years. I'm real concerned that we don't all get painted with the same very broad brush. I know where some problem areas are, but I can tell you exactly what our trends are. I can also tell you that there's not a payer out there with whom I have a contract for on behalf of these hospitals that isn't limited to a percentage increase on their charge masters. And while you may see examples sometimes of people that, the charge is 500% of Medicare, you also see things where their charge is below Medicare. Charge master, again, is all over the board. But these things are known, and largely they're trying to comply with current legislation in terms of what their top 10s are. But a lot of times, the question is like, how much does a 2-bedroom house cost? Those that are in the business know the variance is just all over the board. But we also know that we get paid like you couldn't pay my mechanic. Hey, you're fixing my transmission. It's already up on the rack, so do my brakes for 50% of that. That's how we get paid by the government, but I don't see where that works anywhere else. But a lot of these things are known, and I'd be glad to share them.
Della Flores-Brennan with the Colorado Consumer Health Initiative. Going back to the affordability and affordability thresholds, you mentioned, Lorez, the affordability threshold that's in the ACA, and I think it's important from our perspective not to go any further above that. And one of the significant flaws in that threshold is that it only looks at premium. We have provided to the Division of Insurance a copy of a report that was done with CCHI and CCLP, the Colorado Center on Law and Policy, about 10 years ago. It was looking at affordability and the affordability threshold, and it took into account cost sharing as well as the premium. And I think it's important when we think about overall affordability that we take all of that into account. And then I would just also echo, yes, we need to be thinking, in order to get there, we do have to think about how we're containing costs in the system and what levers are available to us to be able to do that.
Great, thank you. I think there was a comment in the back. Oh, in the front, and then we'll go back. Yes, sir.
I'm John Reeves. I'm an independent broker, and I specialize in small group and individual. One thing that really, as brokers, we see as real tough is in the small group market. It was addressed a little bit over here in the sense that if we offer small group to a 5-person group and somebody has a stay-at-home mom with 3 kids, which is very common, we cannot get them any kind of public help at all. They have to go full boat through an ACA plan, which makes a lot of affordability for those families unsustainable. So you've got businesses that are offering, but they can't afford as a small business to offer it to the whole family. So something needs to be done for those families, and they may be right at 9%. You see what I'm saying? So something needs to be done as to affordability for them. Give them another option. Allow us to offer them some kind of subsistence.
Great.
Hi, good morning. My name is Barbara Gordon. I'm with A+ Smart Health Insurance Agency. I'm a broker, independent broker for small group, large group, and individuals. So I'm going to echo John on this. My big concern right now with trying to tie small group into this public option is that small group currently is based already on overall claims rates. We have seen those rates come down dramatically. I feel like those people who are eligible for small group health insurance should be able to maintain that. I don't feel like the state should put their fingers in on that at all. It's running beautifully. We don't want to mess it up. The second issue I've got with the public option, my big concern, I agree, is with its longevity. My issue is that right now, as of the last, let's say 3-4 years, we have lost one carrier, which was considered something akin to a public option, our Colorado Health Op. That one was sustained by federal money, and it did not sustain due to a lack of federal money. If we're going to ask for money towards a public option, we really need to be careful about whether or not it's received before we even offer it. Second issue being that Kaiser, I believe just yesterday, released that they will no longer be covering anybody in the mountains at all. So, you know, their stability for a nonprofit is questionable. They're unfortunately going through their own growing pains, and they are, I guess you say, backing off. So a public option, well, at the moment, we do have Connect for Health that seems to be putting together people with the public option. I'm not saying don't offer a new one. I'm saying tread carefully. Don't try and rush this through. I want to be sure of our steps. We want to protect the consumer every single time without fail. Yeah, putting the cart before the horse to rapidly finish it, not a good plan. Slow, steady, smart.
Thank you. Okay, we're going to go in the back middle just because we'll hit some of the back now.
Hi, my name is Helene Stout, HBS Consulting, and I have to echo, not rushing the process, of course, but one of the things I'm a little bit confused about, because I'm hearing mixed messages about charge versus reimbursement in our discussion about cost. And we know that a hospital may charge 5,000% of the cost, but what they get reimbursed is not 5,000. So I recently saw a bill for somebody that I represent that was $88,000 for a week in a hospital. The reimbursement, the total reimbursement, patients out of pocket plus insurance, was $6,000. So, and that wasn't a commercial carrier, but that's not really the point. The point is to make sure that we're looking at reimbursement and not necessarily charge, because charge is fantasy. When we look at physician billing, they charge about 200 to 300% of Medicare, but they're reimbursed around 130 to 150% of Medicare, whether that be the commercial portion or the Medicaid, which is less than 100% of Medicare. So I just feel like we really need to caution the discussion to be clear about whether we're talking charges are we trying to fix, cost are we trying to fix, or reimbursement are we trying to fix. And when we talk about cost, let's be careful to address real numbers, not fake numbers. The second thing I'd like to say is in the affordability category, the ACA and the exchange do not address the total population. There's a huge gap in the population. Though I'd like to not reveal my age, I am paying a 3x premium because of my age, not because I'm not healthy. So I dropped $12,000 a year in premium with a $7,500 deductible. Total out of pocket for me is $12,000. Total out of pocket for my insurer is $300 for my annual wellness visit, because that's all I use. Now, maybe I'm the exception to the rule, but I don't really know that. I know that $12,000 a year in my current state is not affordable, well more than any mortgage. And I think that we tend to talk a lot about the poor, the underprivileged, the West Slope, the East Slope, the mountain towns. It's truly not affordable for anybody, whether you work or not. $1,000 a month in a premium you're never going to get back is not affordable. I would be all for saying, okay, I'll give you my $12,000 as my prepaid, but at the end of the year, if I don't use my insurance at all, I want half of that back because I didn't use it. It's a prepaid benefit that is paying for nothing.
Okay, thank you. So what I'm going to encourage, I can tell there is a lot of enthusiasm and excitement about cost of care. I have heard clearly sustainability is of concern for both, consumers and long term. So those are both duly noted. What I'd love to do is make sure we have all the conversation we want on affordability. So I would like to focus people's comments on affordability if we can sort of focus it that way for at least a few more minutes.
Hi, Miranda Ross. I'm an actuary with Kaiser Permanente. And when we talk about affordability, the definitions are always focused on premiums, copays, deductibles, et cetera. But those are all a symptom. And I want to make sure, I know it says at the bottom that we will talk about cost of care, but I want to make sure that that's really the focus, because premiums are going up because costs are going up. The premiums are regulated already. I'm not saying they shouldn't be regulated more, but they're already regulated. What's not regulated is the costs that go into those premiums.
Great, thank you.
Hi, Gary Manchelenko. I'm an independent broker. One of the things I hear a lot from my clients is they want options. So when you look at affordability, there really isn't options. When you truly look at plans, there really aren't very many options. They're all pretty standard. And a lot of times clients are just buying your network. That's all they're doing. Because from option A to option B, you get 2 copays, you get $75 urgent care, you get a $6,000 deductible, a $7,950 max out of pocket, 60/40 coinsurance. They're pretty canned. You're buying more of a commodity than you are choice. When we're talking affordability, I have a lot of clients that say, you know what, I don't want anything other than catastrophic. I love to go to a direct primary care, pay my monthly benefit. I get to see them as often as I want. They treat chronic care. They want to do that. We just want to get down to a basic catastrophic type plan. Don't throw in all the other stuff because I never use it. I don't want it. So when we talk about affordability, I think that's something that really should be taken a look at. I understand that the ACA has rules in place, but if you're going to put a public option and you're going to attract some people want just a real basic, down dirty, give me a $6,000 deductible max out of pocket, $8,000 max for my family, and I'm good. I'll pay it and I'm good. And that'll address a lot of people who are over the 400% in the federal poverty level, because a lot of them already have the money that they're paying out of pocket for providers. They're also paying hundreds of dollars a month to some providers on concierge service just for the right to see their doctor when they're already billing the insurance company and they got to pay the copay on top of it. So there's things in the market that people really want, and the ACA hasn't addressed it. And we're losing options, and we really don't have options.
Thank you.
Most clients are on bronze plans, so.
The mic is coming.
Again, it's Paula Stepp, and I'm listening and I'm hearing all of this, but I really want to bring it back to the consumer. A $6,000 deductible for somebody making $40,000 a year or $50,000 a year is a lot of money if something happens. And that's, I think, why this came before the legislature is, how do we help these people? First of all, you're going to charge me on the Western Slope somewhere between $1,000 to $2,000 for an individual to get insurance. And then you're going to throw on a $6,000 deductible. I can tell you a story specifically of somebody going to get an MRI for a procedure and going in ahead of time, calling to say, what's that procedure going to cost? Finding something happening during the procedure that they had to extend that procedure and do additional stuff. And the next question is, what's my cost going to be now? Because you don't know. So I think we really have to drive it back to why this came before the legislature, which is to our consumers and the consumers that really need the help. And we're not talking poverty level. We're talking people who have what you would think is an adequate income. Throw that on top of affordable housing, and especially on the Western Slope, but I know you're hitting in Denver and in Boulder. That's a lot of stuff to take out of pocket.
Great, thank you. I think Hillary.
Hi, I'm Hillary Hilton with Hasfield, Colorado, and I just wanted to add a few of the things that we talked today. I think that if we solely focus on premiums, we would be slowly missing the mark for affordability. Our organization spends a lot of time traveling around the state talking to people, and we met a lot of people who are uninsured, but we also met a lot of people who have insurance, but they literally cannot afford to use it. And so I think just looking at premiums is really going to miss the mark. So, consumers, I would also echo Anna's earlier comments, and I think the affordability standards in the ACA are not adequate, and we should be looking at something less than 9.6%.
All right, 2 more comments, and then we'll go to or 1 more, and then we'll go, or 2 more. We'll go right back there and then go to the webinar.
Hi, this is Jody Ewell from Bright Health, and I agree that the consumer is what brought this up, but the reason an actuary spoke is because you have to get to the root of the problem. And if you're just addressing the consumer with subsidies or other things, that doesn't solve the problem. You've got to get to the root of it.
Great. All right, Vince, are there some comments related to affordability?
Yes, absolutely. Melanie Herman asks, this is a comment on affordability. The idea of aiming this towards people with chronic health needs may create an unsustainable model because of the high claims for that population. This really has to be for anyone whose premium deductible is unaffordable. And Don Meyer asks, how is this affordable health coverage option going to be funded? Federal dollars, taxpayer dollars? And someone else, Melanie Herman also asks, the cost of premiums plus deductibles for the older population is expensive. So she seconds what somebody said there. And one more. We should encourage employers to offer health insurance to employees and allow those families to take part in the public option or the exchange. This will require some study. Now from Cindy Peterson.
Thank you. So again, hearing a lot around the cost of care. So again, duly noted, and I think they've both heard the charge there. Any, yep, Allison, yes, please. Bethany. Oh, why do I keep on doing that? So sorry, I'm not going to call any names.
Allison.
Yeah.
Quick caller and much I want to add to Hillary's comment about affordability and underinsurance, that the inability to access regular primary care has been an issue beyond just preventive services. And I think we would be interested in exploring options that allowed more pre-deductible primary care. And I think that's consistent with other state efforts. So whether that looks like a standardized plan or whether it's just simply principles about more pre-deductible care, I think that would add a lot to affordability for families and others.
Thanks, Bethany. Sorry. Right.
Just a quick question. How is this going to be funded? What do we know?
So why don't we,
So that's why we're having this discussion, right? I mean, candidly, before we can figure out how we're going to fund it, we have to figure out, we need your input on what you all think it's going to be. So that's exactly why we're having this discussion. So turn it all back to you to say, and I mean, I think we've fleshed it out a little bit about what we think it should be, but we haven't really put a lot of meat on the bones past what I think Bethany just said. So we all agree the cost of care have to be in there, but this is the opportunity, folks. So the carriers in the room that haven't had a lot to say so far, Ryan, if you've got thoughts on the primary care piece, let's talk.
I'm Allison Somerton. I'm from the Aurora Mental Health Center. I am a Connector Health Funded Assistance site. My team enrolls about 3,300 people a year, Marketplace and Medicaid. And I end up apologizing in our enrollment meetings because we have such a complicated healthcare system. And we haven't put on here, one thing we haven't listed is how do we simplify? We have how many plans on our Connect for Health Colorado site? And to try and explain that to someone who has not had health insurance before or hasn't really had to use their health insurance before, to explain the interplay between co-pays, deductibles, co-insurance, and your premiums at the same time. So we've not talked about how this plan could be structured, but I would like to structure it an agreement with Bethany that one, we allow and we create more incentives to access primary care by having more primary care visits without subject to the deductible. But I also would like to structure these so that the whole thing is fewer plans, fewer complications of the plans to make it more accessible for people.
So are there other thoughts on the standardized plan, sort of this idea, this thought?
I'm not sure I'm going to address that question. I just have a general comment.
If you could also introduce yourself. Thank you.
Keith Taylor. I am an independent broker.
Yes, sir. Thank you.
Small group, senior, and individual. So it appears to me that we're going to offer a public option. I wonder about the interplay between this public option and the existing carriers in the state. Let's say you come up with this product. It's priced in such a way that, let's say it dominates the market. Let's say the other carriers don't want to play against a state-funded option. They pull. Now we're left with a single-payer option. I'm sure you've considered this. Is this a back door to a single payer where there's only the one carrier? I don't know that I believe totally in the government's ability to do a better job offering this product than Anthem, Blue Cross, United Healthcare, that's their job. And this is something the state's picking up. I have some legitimate concern about your ability to follow through as a single payer system.
I just want to make sure that we have other people. If you're going to echo or ditto, both sides. Okay, perfect. Thank you.
Yeah, I just wanted to respond to what the lady said over there when we're talking about federal funding versus state funding. It's kind of an interesting dilemma because you do have the funding restrictions at the state side. But I think Commissioner Conway talked a little bit about it last time about the lessons of Colorado Health Op. Federal funding is somewhat unpredictable, and it can certainly change. It certainly did for Health Op in a very big way. And the kind of startup that you're seeing with Colorado Health Op and what we're doing with the public option, there's a lot of parallels. And I think that's going to be rather important to figure out whether that risk is something that you want to pursue and what are the downsides if you don't pursue it, because obviously you're going to be under a more restricted funding picture. But I completely agree with that. There are a lot of lessons there that we have to pay some real close attention to. So I would just want to say that's something that you should all really start thinking about now, irrespective of who you want to cover or don't want to cover. What are the risks attached to that federal funding, and is that a value add at the end of the day?
And what I'll just say, just because maybe not everybody was able to be at the first meeting, there were some core principles outlined, including sort of not destabilizing the market, sort of it's about options, and talked about sort of some lessons learned from the co-op. So again, each meeting builds on another. So I would encourage on the website that we'll show later all the information and materials from the past meetings, because these are very real concerns that I think everybody is trying to think about. How do we learn from what has already happened? How do we really be thoughtful about what it means for somebody to have had coverage and lose it because the insurance carrier is not there? So I just want to, I know there have been a lot of comments and concerns about how do we proceed and how do we proceed thoughtfully. And that's what we're trying to do also, is just get this feedback and input to help inform each step and bring you all along the way. And so an important piece to this, to echo what the commissioner said, is there are still a lot of people we haven't heard from. Each of these conversations helps start to pull together and start to build the model. So this is something that where I'll say is you need to share your comments and thoughts. If it's not being expressed right now, we'll give you the website and email to do that. But again, just know that by not saying something or not saying what you really want to say, we're not going to be able to include that or change course later on as we are moving down this path. So I encourage everyone to speak, please. Yes.
To that end, every stakeholder has a different need and a different opinion about affordability. That's clear because we're all on different parts of the spectrum. But one of the questions I have, or one of the thoughts that I've had thinking about this over time, is as a self-funded employer, one of the things that we're told by the commercial carriers who do TPA type coverage is the reinsurance is very expensive for mid-size under between 50 and 100 employee groups. So if the state were able to create a situation where there was tiered reinsurance, where the commercial carrier covers the first level of reinsurance, the state covers the second, the Fed covers the third, and the liability therefore is spread out over a bigger and bigger organization, then perhaps we could start to see some of the affordability come into view.
Thank you. Ryan.
Ryan Bealey with the Colorado Academy of Family Physicians. So I was requested to speak, so I should. I think a couple of considerations that we would have from a primary care standpoint. For one thing, if you're going to be looking at tagging this plan to a percent of income, I think you really have to consider not only the premium but the cost sharing components of that, because really you're never going to be able to access care if you paid your premium and then you have no dollars left to pay your deductible. So I think that should be considered. The other thing is, and this relates to another bill that we were advocates for, House Bill 1233, which is the primary care investment bill, which has affordability components in there as well. I would agree with Bethany earlier when she said you generally currently in the current system don't have first dollar coverage of primary care. And if we're looking at value-based or value-driven insurance design, we have to incentivize primary care with lower or fewer costs. I mean, the moment somebody walks in for a preventive visit, but something is found, that becomes a non-preventive visit, and then there are suddenly costs attached to that visit. So while we're getting people in the door, we can't address those conditions in a primary care setting without incurring costs. I mean, if that visit, turns into, blood pressure, high blood pressure, something like that, then suddenly the cost of that visit with a deductible could be, $100 or $200. So we would encourage this, the plan design here to drive affordability, and as a component of that, incentivizing primary care and ensuring there's first dollar coverage for primary care is what's going to address those underlying costs of care, which when somebody goes in for high blood pressure but they can't get it addressed, in that case they're going to wait until they go to the emergency room, and we know the story from there. So those are a couple pieces I would add.
Catherine.
Hi, Catherine Millardy with the Colorado Hospital Association. A couple of comments. First, Laura, thanks for kind of outlining the need to make some decisions on the front end. I agree with that. However, I would encourage us to try to find a decision-making mechanism that allows for flexibility later on. I think certainly if we all had our druthers, it would be affordability for all, public option or not, right? Figure it out. But at the end of the day, there will be programmatic constraints, and whether that's a funding constraint or an operational constraint, or as this gentleman in the front row mentioned, constraints due to potential impacts on other components of the market. I think those are issues we haven't gotten to that will probably impact the decisions we would like to make up front. And so to the extent we can do some prioritization or other kind of conditional decision-making structure, I think that would be helpful. Certainly appreciate the interest in wanting to look at affordability not only through the lens of the end user, the consumer, but also kind of throughout the full spectrum of care. I'm not blind to the fact that there's a lot of focus on hospitals, but I'd like to remind this group that hospitals are about 1/3 of total costs. And certainly while there's some activity that we can be doing there, we've got 2/3 that we're not looking at very closely. And we should certainly put some focus in other areas as well. And although it may sound self-serving for me to provide that perspective as a hospital association, ultimately our end goal is making sure that we can continue to provide accessible, high-quality care all across the state, whether that's in rural hospitals or here along the Front Range. And I think while there's a lot of focus on affordability, and there should be, it's a huge concern, we need to also balance our decisions with the fact that too much focus on just affordability may require some really tough choices or force some decisions around whether we can continue to offer accessible, high-quality care.
Any other comments on affordability?
AJ Earls, independent broker. I'm hearing a lot of conversation about the driving costs, et cetera, but there is already other legislation, other things going into looking at transparency, et cetera. What I understood this to be was a state option for insurance, not a completely different reinvention of the wheel. I may be naive, and I'm not sure I understand everything going into this, but what is the difficulty of taking a group like PARA or whatever large group and just allowing people to buy into that? Just another option. I realize that Allison wants to pare the options down, but what would it hurt to just put a large group that's already functioning as a large group, just make that available to everyone through the state?
Sure.
So there's a number of issues that would pop up. First, if this was a group product, then we wouldn't have any tax credits for folks, right? So that would be the first and foremost. The other piece, if you're talking about adding the individual market into some states have gone down the path of combining their individual and their small group market. They did that at the beginning of the ACA, but to the points that were made at the beginning, that will have impacts on the small group market, right? Then you're mixing the risk between the two, and there are going to be impacts that we would have to think through and all sorts of different problems. But more directly to your question, the idea of trying to combine the individual with a large group, whether it was PARA or the employee plan, then you're going back to that risk problem, right? Then you're putting all of the risk from the individual market into the risk pool with whatever that large group is. That will have very serious impacts that we would have to think through. And I don't think, candidly, AJ, at the end of the day, after we looked at those and what that would mean for PARA or the employee plan, that we would end up there.
Thank you. Steve.
Steve Erkenbrack with Rocky Mountain Health Plans. I'm going to echo the commissioner's comments in a little different context. And that is, I've sat here listening, and many of the comments are talking about my chunk of the market. Now, that was in Western Colorado. I'm so glad to see so many of my neighbors here. Or whether it's the small group market, or whether it's, I would encourage us as we do this to look at the impact of affordability on everything. And AJ's and the commissioner just gave a great illustration of that. To say, let's take this and put it over there. You need to not only look at this part that you're trying to fix, but the part that's going to be impacted, and that's the interconnection of healthcare. And so The only point I would say is broaden out from just wherever the target population winds up to its impact on that, but also the other affected parts of this series of dominoes we have. Thanks.
Great, thank you. So again, I think that sort of comment theme has come up a few times, so I just want to re-articulate it. It's very important, what I've heard to everybody is that we understand that if this public option is created, that we really understand the impact on the rest of the market, and that we're not looking to destabilize anything, generally sort of the choices that people have. Is that a fair sort of, trying to generally summarize, not address everybody's needs, but I just want to recognize we're hearing that sort of through a couple different ways, that really understanding the impact. Yes, sir.
John Levitt, again. Microphone hates a vacuum just like nature does. You're already disrupting the market. I know that your intent is not to do that, not to destabilize things. There's a major payer right now that is so scared of what's going on in this room right now that they're running all over rural Colorado, and they're having discussions with rural hospitals that are based on cost-based or discount off of charges contracts. And they're presenting them with ultimatums that, in terms of, here's a new set of rates we want you to consider. These are world-class rates, of course, do what you can. But they're threatening to throw people that don't agree out of that network altogether. So it's already destabilizing. The other thing that I would like to add, and I intend to stay in this process through the whole thing, but if we make a public option look like a Christmas tree, it's not going to be affordable. You know, the well-intentioned ACA, I wanted to keep my plan. I liked it. I was promised I could. I couldn't because it didn't offer OB coverage. Well, I can tell you right now, there's me and an assistant. If either one of us had an OB issue, we wouldn't have needed insurance forever. We'd be paid for the story. But we didn't need OB insurance. It was biologically impossible. The comment was made by a broker about why can't we have a catastrophic plan? Why can't we have a plan when we're looking at federal waivers where you've got a primary care component and a catastrophic, and let people do something about the middle ground? They've got to understand insurance. They somehow have to. I can't think of a more boring thing to try to teach most people. But if you make it look like a Christmas tree with all the things that we know people need on a social basis, it won't be affordable.
Thank you. And then we'll go to the computer for comments. Just trying to see if there's any more hands that want to say something about affordability or sort of, and if not, we'll move on to the next item.
I'm going to stand for this one because I really want people to hear this. So from the broker side, and this is actually part of a group of brokers numbering over 20 in private conversations, our biggest concern is that this public option fits price so cheaply. Like we talked about, it would destabilize the market. The real issue, the real crux of this is less to do with carriers, although they are important. They're a part of our care. The real issue is that when and if they left the marketplace due to the market being destabilized, which they'll look at the numbers and they'll go, okay? Then it becomes this Colorado CARES problem, instantly in a zone of where we are now funding everybody's individual plans or small group or large group or whatever the state decides it wants to take, okay? All of a sudden, the claims get actualized. And what we thought would be something like a 12% payroll deduction turns into more like 35. The state says it still is not affordable. We start cutting corners on that care. And then here we are in a marketplace that is crashing. We've got nothing left. The carriers have lost faith. They're gone. This is my fear as an individual, as a mother of 6. I don't want my children to be in a zone where they cannot have care at all. I mean, we sit here to complain about a $6,000 deductible and doctor visits. What about no care? What about no doctors? What about hospitals that are saying, you know what, we can't trust anything else is going to pay, so you pay up front cash? Sorry. That's a lot more scary to me. So I want to be sure we do protect the marketplace and choice. Our consumers deserve that. I mean, again, as a broker, to sit down in front of parents and, you know, new young people coming on the market, they've got to have an opportunity to understand all their options, which is why the broker community really needs to be involved with this. We explain care to many. Everybody needs to understand their plan before they buy it. That's our pleasure to do it. So that's my comment.
Thank you. Any other last comments in the room? Otherwise, we'll go to the webinar. And I will own there are polls. So if you're sitting behind a poll and I can't see you, that is, all right, Vince, affordability comments or?
Yeah, and affordability and structure.
Okay.
Jennifer Brooks, I'm an independent broker and I've long wanted to see a zero deductible straight up 50-50 plan for all costs, doctors, hospitals, et cetera, with out-of-pocket maximum based on an individual's income. Higher income would have higher out-of-pocket. Claims would be simplified for providers, carriers, and consumers. Simplicity would be the key. Got another one? Cindy Peterson offers this. I think in putting this program together, you should implement clinics in high population areas that individuals on the plan will be required to use in order to receive the benefit. We have many young physicians and physician assistants in school and graduation that we pay off some of their schooling in lieu of their expertise in treating the members of this plan. We need to help people, but must also work to allow the free market to work. And one last one, Melanie Herman. She says, everyone needs to understand that as we are talking about affordability, there's a huge difference between affordability for the consumer and the insurer. There's a reason the premium deductibles are so high and keep going up, because the costs as a whole actually reflect that. Insurers spend at least 80% of their premiums on claims directly, so the idea of just lowering deductibles and premiums is not feasible. It won't work. And Jennifer Brooks also said, let's have less focus on this undefinable affordability and more focus on lowering the total cost of care.
So that is a great comment and a great transition point for me. So not everybody got to say something. We'll have one last comment, so two last comments so that everybody gets to say something. But then what I would welcome is any thoughts that maybe weren't expressed. At the end, there'll be a website and an email that you all can send it to. And if you have seen good, thoughtful definitions of affordability, because we've heard a lot of different variation, but if you all have thoughts on what that definition could be or should be, or at least a start of what should be included in that, I would ask that you email that to us as well. So that is part of your homework. Again, not only you, but to reach out to your networks, but to think about what is affordability, what a definition could look like. And so we'll take two more comments and then we'll move to the next slide.
I actually just had a question based on a lot of the comments we've heard about concerns with what will happen to the market. Is there intent to, based on whatever options are put forward, to commission a study on what that actually would do to the market and what it would look like?
So we've got to come out with a recommendation by November 15th. Part of that, obviously, we have funds that we can that we're tasked to spend on all sorts of different things. Actuarial studies will be a component of it. Will we specifically have something that looks at the long-term impacts of the market? We haven't gotten that far to figure that piece out. And that's true. 1176, I mean, some of the conversation I think that we're having here will bleed over into the 1176 conversations too.
Great. One last comment for this issue.
Thanks, Perez. This is Mark Reese with CVS Health. I think in trying to summarize in my brain what I've heard about affordability, it's interesting because we've heard everything from I need more coverage with less cost sharing to give me a catastrophic plan. If you think back 5-6 years, that's exactly what the ACA actually tried to do with its catastrophic through gold tiering of plans. And so I think knowing that we've tried to have a regulatory environment that actually accounts for variation and cost sharing, which is a variation in affordability based on what people can afford out of pocket premium cost sharing mix. I think that a secondary component of this affordability conversation needs to be kind of the education around what is your plan, what are you buying? Certainly the broker community plays a big role, C4 plays a big role, but what we've done to date has clearly failed. People don't have the plan that is right for them based on this conversation, what we're hearing today. So as we mix the affordability conversation, I think we just need to keep in mind an education component around, if we do have a public option, ultimately, what is that coverage and what does it actually mean for your pocketbook?
Great, thank you. All right, so we are going to move on to, just wanted to sort of, you know, some of the goals of affordability that sort of at least have been thought about is, you know, driving affordability changes in the delivery system, cost of care, encourage behavior change among consumers, medical professionals, or institutions to lower total cost of care, improve health outcomes, achieve per dollar spent, holding insurers accountable for passing savings through consumers. So just some of the thinking about affordability sort of ties into some of those, a lot of the cost and sustainability issues talked about. So I just want to recognize that. Again, if you have additional thoughts of other goals, that is something you can email with sort of affordability definitions. But we wanted to get to another part of the legislation. In the bill, it states a state option for health coverage that uses existing state healthcare infrastructure may decrease costs for Coloradans, increase competition, and improve access to high quality, affordable, and efficient healthcare. And we wanted to get a sense of what that means to you. Again, there were a lot of authors to this. There were a lot of people that were involved in this. And so it can sometimes, as we see, even affordability can mean very many different things to other folks. So just wanted to get a sense from folks, what does this mean to you?
Jack Peter.
Jack, just one second.
Sure. Jack Peter, Planned Parenthood. Would you go back real fast to the list of the goals of affordability? So I'm concerned that one of our goals of affordability, I think this answers your next question as well, isn't that more people can access health care.
Okay.
That seems like
it is the overarching theme, but we will be more explicit about it. Again, I will ask that, yeah, so again, it is the whole purpose of affordability is so that more people can afford the care and the different parts of it. So, but we can be more explicit about that. Was there something else that was missing in your?
No, I think, again, I mean, in answer to the next question, what it means to me and to us as a provider, right, is that everyone can access the care that they need. Obviously, we have anxiety that this would, you know, specifically prohibit people from having their insurance pay for abortion care. But I think that broadly, making sure that all Coloradans can access care without, you know, having to forego groceries is critical.
So, use existing state healthcare infrastructure. What does that mean to you all?
Yeah. We're anticipating that you plan to use the Medicaid network.
And so, do you want to elaborate, as the mic comes over, would you like to elaborate good, bad, indifferent? I mean, what, just to say use Medicaid system, is that something you'd want or not want, or?
Renee Schiffauer, broker. I guess my concern if we use the Medicaid system is the lack of good quality doctors that are willing to participate at a lower reimbursement. And brokers getting paid. Yeah, both of those are pretty key. But it's, you know, impossible to find an orthopedic surgeon that will take Medicaid. Most won't even touch Medicare. So finding those specialists would be a significant concern. And I'm not talking for the rural area, more just in the Denver metro, my area that I'm more familiar with.
Great.
I think if you use the Medicaid network, you can guarantee this plan is going to have problems. Sorry, but I don't feel like we have enough providers.
Okay. Adela?
So in thinking about infrastructure, I do think Medicaid is one of those pieces of the state infrastructure that we could leverage. It doesn't necessarily mean that we're forced to think about the same network or the same reimbursement rates, but perhaps being able to think about how we use that 1.3 million lives, or those 1.3 million lives, to increase purchasing power is a possibility. Maybe not legally or regularly, but I think it's worth exploring how we might be able to do that. If you think about all of the different
groups that the state is in some way purchasing healthcare for, if we can aggregate all of that power, maybe we have a little bit more negotiating power. I also think, of course, that the state exchange is a piece of infrastructure that we might be able to consider leveraging in some way as a shopping portal or perhaps in other ways. And then I think it's already been mentioned, but the state employee health plan is also another potential piece of infrastructure we could look at some way to leverage.
Hi, Gary Manchelenko, broker again. When I take a look at the state infrastructure, I also look at all the carriers that are in place. They're a huge infrastructure, all the hospital systems, the amalgamation of hospital systems with primary care physicians and everything else. You've got 1.3 million that was stated on Medicaid. Clearly, Medicaid reimbursement rates are not palatable for a lot of physicians, and that's fine. But whatever, I would suggest whatever it is that you guys decide to do to help drive down cost of care, however it be reimbursement rates or whatnot, I think to help drive competition within all the carriers, it should be an equal playing field for everyone. So the Anthems, the Brights, the Humanas, the Uniteds all get to play in the same reimbursement rates. So now your consumers have your choice. They can choose how affordable their plans are, and we're driving down the cost overall, not just through your plan, but through the whole plan, because some consumers may not want your plan, but they like this plan. And if we don't help the overall market, then I think we're kind of missing a big point.
Carol Pace, I'm a consumer. I agree with much of what has been said, that the entire infrastructure that currently exists, I would anticipate to be the infrastructure in the future, whether it's Kaiser bidding to healthcare choice that is added to the exchange. I think all the infrastructure continues to be there. The very stunning and impressive figure that was quoted last meeting by Kim was that she's able to run her health plan for 4.5% overhead. I think that is a major key issue related to standardization, streamlining, anything you want to call it, that we can get there to be less busy work in the whole system that causes also the cost to go up. But I'm very impressed. I would be delighted to see HCPF in charge of a plan if they can do administration on 4.5%.
Other thoughts on infrastructure? Yes, sir. Yep.
Steve Reynolds. And one of the things we want to keep in mind when we talk about the existing infrastructure is the lack of services that are available in a lot of our rural areas. And I don't know that it gets changed, but the fact is, if you get into some of the rural areas of any state, in ours especially Colorado, we have some pretty significant shortfalls as far as services.
Thank you. Ian, sorry. We'll come back there.
Hi, I'm Patty Meyer with Benefit Mall, and I would like people to look at maybe expanding telemedicine, things like bringing that kind of option to the rural areas, things like Dispatch Health, which is a mobile unit of healthcare, and maybe possibly using that in our rural areas where there isn't a lot of access. I know that they would probably need state money to help them cover those areas, but that might be an option outside of what we already have or what's being used optimally.
Any other thoughts on infrastructure? Oh, yep, sorry.
Paula Stepp again. I just needed a little clarity because when I look at using existing state healthcare infrastructure and thinking on the Medicaid that you guys had brought up, I did not see this as you're going to just give consumers healthcare. I saw it as them buying into a system so that they would have lower rates through a state system. I'm just looking for some clarity there.
That's why we're having the discussion. I hate to keep saying that, but as you've heard in the room, there's lots of different thoughts about what this state of healthcare infrastructure means and where we should go with it. And I think that's why exactly we wanted to have this conversation. It's gone places that I didn't anticipate, to be candid.
Okay, because I really don't think people are expecting to get free health care. I just think they're looking for lower options.
Thank you.
Helene Stout. I would like to see the state infrastructure create a series of consistent simplifications that are applicable across the entire industry and every payer that participates in the state. The process of contracting with a healthcare payer, the process of buying insurance, the process of researching insurance is all become too complicated. And if this committee does nothing but create a bunch of simplifications that if you participate in this state, you need to follow them, I think that would drive down administrative costs. It would use the existing infrastructure to provide guidance across the board to everyone.
All right. Ryan?
So I just wanted to add a couple notes about using the Medicaid infrastructure. I think to Carol's point, the administrative savings from that could be really tremendous. Sorry, I wasn't close enough to the microphone. The administrative savings from using the Medicaid infrastructure could be really substantial. We could also look at, the third-party arrangements, sort of regional TPAs or something like that. But if we do use the Medicaid infrastructure, I think one thing I'd want to emphasize is the importance of a smooth transition to using that infrastructure for claims payments. So, when we transitioned to the new DXC technology, that was incredibly challenging for providers in the states, and it jeopardized access to care for many Medicaid patients. And so I would want to ensure that any transition would would not, push those costs onto the practices and ensure that they're getting paid quickly and efficiently. Otherwise, we jeopardize not only the success of a public option like this, but also the current existing Medicaid reputation and patients in this state. So, thanks.
Great, thank you. So there was also a question from the last meeting, so I want to make sure we have time to walk through that. So are there any last comments? Okay. Yep.
I've been just listening to the input, and it's good input, and I'm looking at this statement, and I think we're building a unicorn. Do we know what the existing state healthcare infrastructure includes? Because there's some very strong and well-intentioned efforts going on right now with the HTP, Hospital Transformation Project, to actually change that infrastructure. To me, this statement is asking that we lower the cost of health insurance and direct pay and not make any hard choices. I don't think we can do this without some real hard choices.
Yeah, no, and again, I think that's a fair comment. Again, we're just trying to get what are people's thoughts, because again, as we've heard, the using existing state healthcare infrastructure has meant many different things to many people, and so really wanted to understand that, as well as heard some of those same themes come back up about a lot of the concerns raised around stability, sustainability, around sort of the importance of how this is going to work for consumers, users. How do we make sure it's affordable? And there will be tough choices. And I think, again, this is helping create a frame to which then recommendations can be developed, shared, and tested against all of these values. So a couple last, yes, sir.
Bob Shively again. I'm a vet and use the facilities as well as I do privately. And because I'm 40 miles distance from Grand Junction, I can use my former family practice physician. At any rate, the questions is, we're dreaming. So it's always occurred to me when I visited the telehealth center in Glenwood Springs that we've got a nice telecommunication piece there that goes unused all too often. And couldn't we share some of those types of things that are being offered? You know, somebody over here said that, especially rurally, that are being offered by the, let's say, the federal government, for lack of, you know, pointing fingers. It would be the VA. That might be a hard tug, but you never know.
Yep, great. Okay, for folks, actually, Vince, I'm not going to have you. All the folks that have commented on the webinar online, they actually stay with us, so we will capture those comments. Again, we are sort of running out close to the end of time, and our job is to share information, but respect your days and time. So I wanted to walk through, or have actually both Kim and Mike walk through. This was a question from last time. What work is currently being done to support and inform this? And so we wanted to give an opportunity for them to talk about some of that work.
So in addition to the stakeholder input, which we really appreciate, thank you for your thoughtfulness and your engagement, we have a Medicaid churn analysis. So when some folks on Medicaid are in difficult chapters and some folks on Medicaid are more chronic, so we're studying why people come on and off of Medicaid so that we can address some of those issues as we think through a public plan. First part of that is due at the end of June, and it will continue in iterations and evolving output. The source of that is largely APCD data and some state CBMS eligibility information. The CHAS survey, which is done by Colorado Health Institute, is due around September 1 or so. So we hope to have great insights into updated numbers. As we said last time, we're a little concerned that those numbers are moving up. So we want to understand uninsured communities they're coming from, both geographic and various groups of folks that buy health care. We have a project plan to create an offering. So all of the things, and as I think I said last time, I've built a couple dozen products in my life that covered every single state, including running a market right here in Colorado. So I built a lot of products on exchange, off exchange, group, individual. So we have a whole process. If that is what you all are guiding us towards, of all the steps that have to do that. And then we have folks and consultants studying potential plan design, or plan designs that are out there now and the costs associated with them. So we have our arms around cost-effective, non-cost-effective, most in demand, et cetera. So those are just some of the pieces while we're querying what your recommendations are.
So from our end, the pieces that we're working on currently are what we're working with to get done by the end of this month, so this fiscal year in particular. First and foremost, we're paying for the res, which we're all very happy about. Then we're doing some basic actuarial analysis. So the bill calls on Kim and I to figure out what provider rates we need to hit in order to actually be able to build a network. So we're going to do some baseline analysis along those lines. Again, with the idea that we will hopefully get that out by roughly the end of June. We're going to do some focus groups to answer, at least in part, the question that was raised earlier about what does it actually mean to be underinsured. I think you heard a lot of what that actually means in the room today. I think it's mostly the cost shares, obviously, but what level of cost share are we hitting for folks where they feel like they actually do have a product that is of benefit to them, or they're actually just underinsured. So that like the woman in the back, Helene, that talked about the fact that she's got the $12,000 premium payment, but then she has the $7,000 deductible as well. Is that just an underinsured product at the end of the day? We are going to do some coverage analysis along the lines of what the other states, what we touched on in the first presentation. So what the other states have looked at so far will be kind of our starting point, but we're going to take some left and right turns from there. It was Manat for that work, at least in part. So the same folks that did the work in New Mexico are going to be helping us out with this initial look. And then we've got a technical consultant that has done a lot of work. His name is Billy Wynn. Some of you may know Billy. He's done a lot of work in this space. He's put out some articles on Kaiser Health News and other places. He's going to help us kind of try and weave our way through the comments that you all had today too.
Great. So again, that was a question from last time. What work is currently going on to help sort of also shape and inform us getting to some of those other meetings? Well, that just did that, but What I wanted to make sure everybody had, most importantly, was the website. It's on the HCPUF website, this PowerPoint, the other PowerPoints, all the meeting notes, the meeting notification. Want to make sure everybody signed in. I know people still registered for the meeting, but I would still ask that you sign in on your way out so we make sure that you are kept up to date and informed of future meetings. The website, the email address is the HCPUF_1004 affordableoption@state.co.us. So a reminder, your homework is to send us some thoughts on an affordability definition. Send us some thoughts on, are there states we should look at or think about? And sort of any other thoughts on this PowerPoint or slide that we might be missing. So we welcome that. That is checked daily, multiple times during a day, so they will not go unnoticed. There will be another meeting. It will probably be in the early, mid-July range, but look to the website and it will be noticed there as well.
Can I add one more thing? So some of you have been working on this issue for minutes, and others of you have been working on it for years. We do want to hear specifically those of you who have built an entire thought process around what is the solution? What is it? We want to give you an opportunity to present that solution. So I would invite you to please be thinking about that, because once we say we need you to present it, we're probably not going to give you a year to prepare. We're going to give you a short period of time. So I would ask you to please put thoughtfully together, start building that together into a PowerPoint of some sort, and Mike and I and the Executive Steering Committee will put together an outline of what we need you to cover. Things like, who are you assuming will take risk? What does this network look like? What is the thought? Who pays for this? Who does it cover? So if you have been working on this for a long time and you feel strongly, we want to give you that avenue. It'll be a limited period of time, but please start putting that together. So when you have that opportunity, you feel prepared. And I appreciate that.
Great. And so with that, I thank you all and enjoy the rest of your day. And thank you for participating now and through this process. We value all your thoughts, comments, and feedback.